So good morning, everybody. Dr. Ellen Bogan isn't available this morning, so I'd like to present this morning's speaker, who is familiar to most of us. Dr. Hauptman is our associate professor of neurosurgery. He is the co-director of the tuberous sclerosis complex program, surgical director of pediatric epilepsy surgery, medical director of the hydrocephalus program, and of course, a part of the Institution of Neurosurgery at Seattle Children's. Jay, maybe not surprisingly, did his BA in psychology and a BS in biology, and of course, summa cum laude, and then went on to Rutgers to do his medical degree. He has a PhD in neuroscience from the University of California, LA, and went on to internship and residency in LA. And somehow we managed to extract him from Los Angeles many years ago, where he has just hit the ground running. And he has over 70 peer-reviewed publications, over 50 presentations nationally, internationally, and a thriving research program, both translational and basic science. And so we're really looking forward to hearing your talk. And Jay, hopefully there'll be some time at the end for questions. And thank you so much for presenting today.
Thank you so much for that super kind introduction, Dr. Kim. I was going to talk today. Thank you everyone for having me. I'm more than happy to fill in for Grand Rounds. I hope you guys find this both entertaining and interesting. Today I was just going to give you a state of the science, so to speak, clinically mainly for epilepsy surgery in children, and then have some research kind of sprinkled in throughout. These are my disclosures, neither of which are particularly relevant, I think, to this talk. This is the most important slide. Neurosurgery and epilepsy surgery in particular is a team sport. Doctors Goldstein and Ojanen have been incredible, steadfast partners in the epilepsy program here at Seattle Children's. Of course, I'd like to call out Andrew Cohen, Ben Grannon, who've been longtime supporters of epilepsy surgery at the UW and in the Grid Lab, and then everyone on this slide. And I am sure that I am missing people, unfortunately, but the program is large and thriving and full of really talented people, many of which are on this phone call today. And I want to thank everyone for their collaboration, because truly this program is the result of many people, not one person. This is what we were going to talk about today. We're going to start at the very beginning, talk about treatment refractory epilepsy, the rationale for surgery, why we do it, what we see, and how we're doing. Starting at the very beginning, after one single unprovoked seizure, the risk of a second is between 40 and 52%. So one unprovoked seizure generally will not get you the diagnosis of epilepsy in your EPIC chart. It requires a second seizure, a second unprovoked non-febrile seizure for you to get labeled as having epilepsy. And the reason for that is after your second non-provoked non-febrile seizure, the chances in 4 years of having another, a third, are nearly certain, between 70 and 90%. Then we rocket forward into when the surgeons come in, treatment-resistant epilepsy. Years ago, now over 20 years ago, there was a landmark natural history study done in New England by Kwan and Brody, in which they just took all children who had been diagnosed with epilepsy and followed them. It was a true natural history study. Had their neurologists manage them medically as they would have regardless. What they found is that beyond 2 anti-seizure medicines, so when children had been trialed on 2 anti-seizure medicines appropriately dosed and tolerated, if 2 did not render the child seizure-free, the chances of a third or a fourth were essentially less than 5%. That 2 anti-seizure medicine threshold became de facto the definition of treatment-resistant epilepsy, and it's a definition we use in both adults and children, and really is like foundational to epilepsy surgery in both adults and children, even though the fields are very similar, but they also have differences. If a child has an MRI positive lesion, the chances of medicines helping is even lower, and that's led to a modification called the one drug failure modification, which we can talk about in a minute. There's a common thought in pediatric epilepsy surgery that if medication trials are ineffectually continued beyond that two medication ceiling, there can be unacceptable neurological morbidity, i.e. we're losing time. And so by definition, treatment-resistant epilepsy is a failure of two appropriately dosed and tolerated anti-seizure medicines. Because having an MRI positive lesion is associated with a much lower chance of remission on medication, we now have what's called the one drug failure. So if the MRI is positive and we think the seizures can be referred to the lesion that you see on MRI, one drug failure is all you need to be considered treatment resistant. I think an important component of this definition is, what does seizure freedom mean? Seizure freedom means at least 3 times the longest interseizure interval, or at least 1 year. So a child that's seizing 10 times a day is technically not considered seizure free until they've been seizure free for a year, not 3 days. And for a child that seizes once a year, it would be 3 years before they're considered seizure free if they haven't had a seizure. So those are common definitions that we use in treatment resistant epilepsy. All of this comes out of, like I said, this Kwan and Brody study, in which the incidence of new onset seizures in children was about 4 per 1,000. 10% of those kids over 2 years will develop treatment resistance, and another 10% of them, even if they're medically controlled over the first year, by the second year, they'll be medically resistant or treatment resistant. So it's not a small problem. It's a large problem. And a lot of the work that we do in epilepsy surgery is trying to identify these children and bring them in sooner for surgical intervention. This Kaplan-Meier curve in the lower right-hand side, the dashed line is no lesion on MRI. The solid line is lesion on MRI. And what you're seeing is what percent are not intractable over time. So if you don't have a lesion on MRI, the likelihood of you remaining not intractable is much, much higher than if you have a lesion. If you have a lesion, it is nearly certain, 80% of those children will be not intractable over 10 to 15 years. That's a huge number. In other words, the likelihood of you being intractable is incredibly high, incredibly high. Why do we intervene early in children? We know that intellectual dysfunction is incredibly common in kids who have uncontrolled epilepsy. In one study, they looked at unilateral temporal lobe epilepsy, and over 60% had IQs under 79. Independent of pathology, we know that intractable seizures in the first 2 years of age is a significant risk factor for intellectual disability. We think that inadequately controlled seizures results in impairments in cognition, language, social skills, and communication, and can result in what we term the epileptic encephalopathy, which is essentially a global encephalopathy affecting all these cognitive domains that is essentially irreversible over time. We know that if we're not controlling seizures, kids are not doing well psychosocially. They have lower rates of school completion, employment, marriage, holding a job, keeping a job, being financially independent. We know that if we intervene early and we're able to, put the seizures in remission, eliminate them entirely, there are improved IQ scores, improved developmental indices. But perhaps the most compelling argument for epilepsy surgery comes out of morbidity and mortality. Sudden unexplained death secondary to epilepsy, what we abbreviate as SUDEP, S-U-D-E-P, is approximately 0.5 to 1% per year cumulative risk over a lifetime. 1% per year cumulative risk is an incredibly high mortality risk for children. That means over 10 years of life, there's a 10% risk of death. Over 20 years of life, a 20% risk of death. I would challenge anyone to come up with a quote unquote benign disease of childhood that has a mortality risk that approaches anywhere near 10 to 20% over 10 to 20 years. This was a survey that was done now over 15 years ago, looking at how we're doing in pediatric epilepsy surgery, and there's certainly room for improvement. On the left-hand side of the screen, what you see is how old kids were who were referred for epilepsy surgery when they started seizing. over half of children who were ultimately referred for epilepsy surgery started seizing in the first 2 years of life. If you look on the right-hand side of the screen, the vast majority of them weren't referred until their late teenage years. That's their age at which they were finally referred. So they're seizing very early on in life, very severely, but it's taking over 10 to 15 years to find these children, identify them, and refer them for epilepsy surgery. And this is an area that we really focus on improving, finding these children, diagnosing them, and getting them early evaluation. By far and away, the most common entity or substrate pathology that we see in epilepsy surgery is cortical dysplasia. Over 40% of children will be on the cortical dysplasia spectrum: hemimegalencephaly, unilobar, multilobar, all the above. Followed by that is going to be tumor, and then some less common etiologies that we'll just kind of fly over. I think everyone on the meeting today knows cortical dysplasia. It can be a mild or severe defect in lamination. It can be grossly abnormal neurons, abnormal apical dendrites pointed the wrong way, cell bodies in white matter, dysmorphic cytomegalic neurons, or even what we call balloon cells. We know that more severe cortical dysplasia is more likely to appear at younger ages, have explosive or higher seizure frequencies, and be outside the temporal lobe, which is very different than what we see in adult epilepsy surgery. We know that radiographically, we're probably only able to detect between 50 and 75% of these cortical dysplasias. Some of them are so subtle that we only see them on histology after resection. And that's something, again, that we're working on in the field, trying to understand how do we better detect these radiographically, ultra macrostructurally, so that we can identify these kids as lesional and present them as surgical candidates earlier, at least understand the extent of the lesion ultrastructurally on MRI. One thing that's been very, very helpful is FDG PET. Approximately 75 to 90% of cases of cortical dysplasia are positive on FDG PET. Most of the time when we see focal cortical dysplasia, it can be frontal or temporal, but sometimes it can involve the entire hemisphere, like hemimegalencephaly. This is the modern histologic classification of cortical dysplasia. And what I think I would just call out here is that type 1 and type 2 really refer to how severe the histological abnormalities are. Type 1 is more subtle. Type 2 is not subtle at all. These are dysmorphic neurons, large cytomegalic interneurons, we think are interneurons, and then balloon cells. And then type 3 is cortical dysplasia plus. Cortical dysplasia can occur with other etiologies. We call that dual pathology. It can occur with MTX. It can occur with glial or glioneuronal tumors, or even next to vascular malformations, or in the setting of old injury. Low-grade tumors like gangliogliomas, DNETs, low-grade gliomas can be associated with cortical dysplasia, can be on their own associated with medically intractable epilepsy, and probably some of our best outcomes come for resection of low-grade cortical lesions, usually with electrocorticography, so that we can define the extent of the resection. Birth-related injuries like perinatal infarcts can lead to medically intractable epilepsy. MCA infarcts are a very common etiology that we see requiring hemispheric disconnection. MTS, which is incredibly common in adults, and Dr. Coe and Dr. Grannon and Dr. Ojanen, senior and junior, are absolute experts in treating. It is very common in adult epilepsy surgery, very uncommon in pediatric epilepsy surgery, and something that when we see, we can sometimes treat like we do in adults with laser ablation or an anterior temporal lobectomy. We always worry with MTS in children that there's dual pathology, like an associated cortical dysplasia. So we really keep our eyes peeled for that in the pediatric population. Sturge-Weber is a particularly fascinating and unusual disease in which there's a port wine stain along the V1 distribution and Peel angiomatosis. A lot of these kids will develop epilepsy. This epilepsy can be severely treatment resistant, lead to developmental delay and progressive hemiparesis. The Sturge-Weber itself is what leads to progressive hemiparesis from the Peel angiomatosis. When these kids come to epilepsy surgery, many times we consider them for hemispheric disconnection or even temporal parietal occipital TPO disconnections, depending on the extent of the Sturge-Weber. And Sturge-Weber is a spectrum. Some are whole hemispheric and some are only hemihemispheric. Tuberous sclerosis is something that Dr. Stephanie Randall, one of our pediatric neurologists here at the Children's Hospital, has spent a career working on, developing, trying to improve the care of, and has led to the creation of our tuberous sclerosis clinic. For the boards, we all know that it's 9q and 16p chromosomal deletions. Seizures are very common. Over 80% of children will be affected by seizures that are likely going to be medically intractable. One of the problems that we have in TS is that it's unlikely to cure them surgically, but there's still a palliative role of surgery for tuber resection to try to get them to maintain or regain developmental velocity that can be lost with severe epilepsy if it's left treated medically alone. One of the challenges that we try to overcome is, which is the tuber? Is it just one? Is it multiple? Sometimes you take out one tuber and another tuber starts lighting up and firing. And so that can be really, really tricky. Stereoelectroencephalography has helped a lot. Ictal-SPECT and FDG PET are really helpful. And then some newer MRI modalities that we pay attention to can be super helpful here too. Rasmussen's encephalitis, which is a very rare condition, but does get some neurosurgery PR because when it does occur, it's quite dramatic. It's an autoimmune encephalitis, we believe, that affects one hemisphere, leads to progressive hemiparesis and intractable epilepsy. A lot of times these kids or even young adults are temporized on steroids or immunoglobulins or plasmapheresis, but ultimately hemispherectomy is the only cure for the epilepsy that we are aware of. Unfortunately, these children will go from being completely normal to being completely debilitated in a few years. And because it's a difficult diagnosis to make, it can take years to make it. Sometimes even biopsies are necessary to prove that it's Rasmussen's encephalitis before physicians are willing to commit to a hemispherectomy. What you see here are MRI findings of a late Rasmussen's encephalitis, but if you catch it really early, it can only be in the temporal pole and the frontal pole, and it might not be enough to clinch that diagnosis and send them to hemispherectomy. Hypothalamic hamartomas are incredibly fascinating developmental malformations. They arise typically between the mammillary bodies and tuber cinereum, and they are characterized by gelastic epilepsy, which for anyone who hasn't seen it is really dramatic. It's laughing without mirth. These kids have laughing fits that they try to suppress. They're very uncomfortable for them, and they're not associated with happiness or euphoria. A lot of times gelastic seizures are the first that we see, but then these kids can have secondary generalization. They can develop medial temporal lobe epilepsy. It can be quite challenging to treat if left untreated. These kids can also have hypothalamic morbidity, central precocious puberty, cognitive behavioral problems. 20 years ago, the mainstay for therapy would have been a transcallosal disconnection or resection. Some centers in Europe and Japan had started doing RFA about 15, 20 years ago. But I would say that one area that's been completely transformed by the introduction of the laser ablation techniques is hypothalamic hamartomas. I would say that the standard of care today is Visualase or its competitor, Monteris laser ablation of these lesions, in which one or two stereotactic trajectories, 1 to 2 nights in the hospital, watching out for endocrinopathy, and then they're home with an incision that's smaller than your pinky fingernail. It's a pretty dramatic change in the way that we manage them. This slide I don't know why the templating got messed up here, but some other unusual pathologies that we see: Landau-Kleffner, which is an epileptic aphasia; hemimegalencephaly, which is a holohemispheric cortical dysplasia; and then polymicrogyria, all of which can be treated surgically. Generally speaking, the surgical approach or pre-surgical evaluation or pre-surgical pipeline is fundamentally no different than it would be in adults. It's an interdisciplinary approach in which patients are, worked up electrophysiologically through imaging and neuropsychologically to try to find the focus where the ictal onset is, understand their level of neurological development and morbidity associated with their epilepsy, so that we know where they start, we know where we can get them to, and that we can track their outcomes over time. Just like in adult epilepsy surgery, video EEG is the mainstay. We look at semiology to try to localize. We look at electrical signatures to at least lateralize. In a lot of kids with, for instance, bifrontal epilepsy or even unilateral frontal epilepsy with rapid spread to the other hemisphere, this can be really, really tricky. In kids with medial ictal onsets, it can be really, really tricky to try to lateralize, and sometimes phase 2 evaluations can be really helpful. But when video EEG lateralizes, that at least sets our sights on a target, especially if the MRI is positive. If the MRI is positive and the video EEG lateralizes to the site of the MRI abnormality, that in and of itself can be both necessary and sufficient to proceed with an epilepsy operation. Our neuropsychologists here at Children's do a phenomenal job doing multi-hour batteries on children, some of which have severe developmental delay, and they deserve a lot of credit because it's really, really tedious and difficult. They also help run the functional MRI program that Jeff Ogeman started now over 15 years ago, in which we're really investigating both intentional task-based fMRI using bold signal, and then also passive resting state fMRI, what we call resting state connectivity fMRI, to understand areas of function and dysfunction through imaging structural connectivity to better, identify disrupted networks or predict outcome or tailor surgery for them. Hannah Goldstein published a terrific paper about a year ago with some of our colleagues in neuropsychology. Hillary Shurtleff was one of the lead authors, looking at tailoring, for instance, temporal lobe resection to functional MRI of memory. And I think that very much is the future of epilepsy surgery, is preserving function, understanding areas of dysfunction, and tailoring surgery to minimize collateral injury to functional neurological systems. 3T is the new standard. 17 might be at some point during our lifetime, but not quite yet. FDG PET really, I think, transformed the localization of cortical dysplasia in particular. We look for areas of hypometabolism interictally. Up to, like I said, 70 to 90% of cortical dysplasia can be hypometabolic interictally on PET. Sometimes even when the MRI is negative, if you co-register PET with MRI, that can be incredibly elucidative to try to find the ictal focus. Harry Shugani, who was originally at UCLA, then moved to Detroit, wrote several seminal papers looking at FDG PET in the setting of cortical dysplasia, and deserves a lot of credit for the work, the foundational work that was laid out looking for that. Ictal SPET, our colleagues at Harborview, Dr. Hakimi and Dr. Poulos and colleagues, have been incredibly helpful and collaborative in our older kids, in which we send for ictal SPET. This is a technetium injection. The difference between PET, which is an interictal study, and SPEC is that it's an ictal study. And so these are kids who you would need to keep close by the scanner, inject them with technetium around the time of the onset of the seizure, and then get them in the scanner. You can imagine that's a Herculean task. Something that really can't be done in young children. And a lot of credit is due to both the technicians and our neurology colleagues at Harborview when they pull this off, because it's magic. And in kids that have tuberous sclerosis, for instance, ictal SPEC can be really helpful to try to localize which is the hot tuber. Just like in our adult colleagues, the surgical approaches really can be put into 4 different categories. You have our phase 2 invasive recordings, and stereoelectroencephalography, I think, has really transformed the field. Subdural grids and strips was the mainstay for a long time, and I think stereo EEG is supplanting subdural grids and strips in many, but not all cases, and we can talk about that. Resection when possible to cut is to cure. We try to go for cure in all children. We believe that 0 seizures is the best mitigation of SUDEP risk, is the best way to restore or maintain developmental velocity, and that can be as small as a temporal lobectomy or even a lesionectomy, or as big as a hemispheric disconnection. When we talk about cases in which we think cure is not possible, we really focus on neuromodulation as an approach. And for a long time, it was really just VNS in children. The last 5 to 10 years has really been transformative in the area of neuromodulation in children. We're applying a lot of principles that were first pioneered in adult epilepsy surgery using deep brain stimulation, particularly to the thalamic nuclei, and then responsive neurostimulation, neuropace, both to cortical and subcortical targets. And we can talk about that a little bit. But that still very much is off-label in children. DBS and RNS are both off-label under the age of 18. However, we are using it more and more every year. There have been some payer challenges in using RNS and DBS, but I think even they recognize that there's a socioeconomic or a direct economic benefit to improve seizure control in these children, and it's very much worth the cost of the neuromodulation operation, even though we many times have to fight with the payers over that. And then palliative disconnection, which I think really what we're talking about is corpus callosotomy. And even though corpus callosotomy really originally had its heyday in the 70s to 90s, it's resurgent. And it's resurgent because we're doing it with a laser. And there's been a lot of increased interest in corpus callosotomy through minimally invasive approaches. We can talk about that a little bit too. I really believe that stereoelectroencephalography has been probably one of, if not the most revolutionary change in epilepsy surgery in the last decade. For those of you who haven't seen the operation, stereoelectroencephalography is essentially stereotactic placement of depth electrodes in cortical and subcortical structures to do prolonged invasive inpatient monitoring. Stereoelectroencephalography is not new. It's been around for over, I think, since the 50s. In the days of Talairac, it was done with the frame. But why it's been revolutionary in the last decade is that with robotic approaches, it's become accessible, particularly in young children. And that, I think, is what really has changed the game. When I was training at UCLA, we were, back in now the early 2000s, and even before that, Itzhak Fried, for instance, was routinely doing stereoelectroencephalography, but he was using the frame. That wasn't something that was felt to be appropriate for young children. He would do digital subtraction angiography in the frame. He would plan using convoluted stereotactic software. And I would say that that's not something that a lot of other surgeons in the community would have embraced. But now, with stereoelectroencephalography being really as easy as planning on the ROSA robotic platform, or now the Medtronic's what's called the Stealth Auto Guide, it's become very accessible. And there are surgeons in the community now that are doing stereoelectroencephalography as they build their epilepsy programs. It's minimally invasive. Studies have shown lower blood loss, shorter operative times, faster recovery, shorter hospital stays after explant. Unfortunately, this does come at a cost, which we can talk about, which is you don't get quite the spatial resolution that you will with subdural grid electrodes. And you also don't get quite the ability to map eloquent cortical structures like you do with subdural grid electrodes. And I think that's worthy of discussion. We can tackle that if people have questions at the end, but it's areas of active investigation. Of course, the mainstay being subdural grid electrodes, in which there's a large, usually hemicraniotomy, duroplasty, a series of grid electrodes placed on the brain surface, implanted. Patients are left in the ICU usually for a night, and then in the EMU for a week. There's usually a planned explant because you require a second craniotomy to explant them, and usually phase 3 definitive treatment, the resection, is done at that time. For everyone on the call who's seen both stereo EEG and subdural grid electrodes, I don't think there's any debate that stereo EEG is much less invasive, is a much faster recovery. I think where the debate exists within pediatric epilepsy surgery is, are you able to localize the same way? Are you able to get that same degree of coverage? Are you able to map the same way? And I think stereo EEG has changed our approach a little bit too, because sometimes with stereo EEG, we might just be looking to lateralize as opposed to localize. Sometimes we might be doing it as a phase 2A. meaning that we just want to lateralize and relatively localize and then go back in with grid electrodes to map eloquent regions, language, or motor, or at the time of surgery, do more elegant brain mapping, whether it be awake or whether it be SSCP phase reversals, direct cortical stimulation. But those are some of the limitations of stereo EEG versus subdural grid electrodes. Pivoting to resection, I think we all know the landmark New England Journal of Medicine article showing, at least in adults, the value of temporal lobectomy versus continued medical therapy for medically intractable epilepsy. I think is really clear in the New England Journal of Medicine article that for those who had unilateral localizable temporal lobe epilepsy, surgical therapy with anterior temporal lobectomy was superior to medical therapy alone, both in the short term and the long term. And follow-up studies looking at longer term outcomes have substantiated that. The longer term outcomes might not be quite exactly the same as they saw in the New England Journal article, but they're pretty close. One of the challenges that we have in pediatric epilepsy surgery is the extratemporal nature of the medically intractable epilepsy. Unlike in adults, where the vast majority of etiologies encountered are going to be temporal lobe, the vast majority of etiologies encountered in pediatric epilepsy surgery are extratemporal. And if there's one thing that we know with certainty, the surgical outcomes are never as good, with the exception of very clearly defined lesions like the calf-mal here. They're never quite as good extratemporally as they are temporally. If you have an MRI positive lesion, extratemporal lobe resection can be very, very effective. But in our MRI negative kids who are extratemporal, we really struggle, I think, to figure out the best way to achieve seizure freedom with surgery in those kids. One thing that we've pushed a lot here in children, starting with a lot of the work that Jeff Ogeman has done over many years, is awake mapping to preserve function. It's something that we're doing in younger and younger children. The youngest child we've done, I think, right now at children is about 8 years old, in which we really strive hard to avoid or preserve, avoid injury to or preserve critical eloquent function, sensory motor, and language being the top two. There's a lot of work that still needs to be done, understanding how to maybe cortically map vision, for instance, and as we become more sophisticated, I know that there's a lot of thought that's been put in by our adult colleagues, Dr. Silbergeld, Dr. Coe, looking at ways of preserving even higher cortical function in our high-performing adults. If you have an aeronautical engineer with a parietal tumor, how do you spare spatial recognition, for instance, and how do you minimize morbidity to get them back to work? And is it the same kind of win if you take out the tumor, but they're unable to return to activities as they were before? I think that's where awake mapping is really, going to be the key. Laser ablation now has been around for over a decade. The SLATE trial has been discontinued. That was the mesial temporal lobe ablation trial that was out of Emory. We participated in that at Harborview for many years. I think that in epilepsy surgery in particular, mesial temporal lobe epilepsy is by far and away the best studied. The bottom line, I think, with laser ablation is that it's clearly less invasive than ATL. It likely has less neurocognitive morbidity than ATL, particularly in the dominant hemisphere. However, it doesn't work as well as ATL, and the seizure-free rates are going to be lower than they would be with an open resection. I think most people would agree with that. And we look at other applications of LIT because it's minimally invasive, because it allows us to access deep subcortical structures without, a large craniotomy or brain retraction. Hypothalamic hamartoma to the right is one of the prime examples of an etiology that's being treated with laser ablation that's transformative. Some of these kids require more than one treatment, but the neurocognitive morbidity, the collateral injury in laser ablation is minimal. Some of these kids may have transient endocrinopathies, and that's about it. And so that's something that we think about a lot, and we're using more and more frequently. Hemispherectomy by far and away is the most dramatic surgery that we do in pediatric epilepsy surgery. Rarely is it done outside of the pediatric population because of the lack of ability or the perceived lack of ability to recover. There may be some ability for older children or adults to recover, but it's not going to be quite the same as our youngest children. In general, hemispherectomy is indicated for catastrophic unilateral hemispheric epilepsy for the most part. These are going to be your perinatal infarcts or severe trauma to one hemisphere, your Rasmussen's encephalitis, your whole hemispheric cortical dysplasia, hemimegalencephaly, Sturge-Weber, or whole hemispheric migrational abnormalities. There are occasions in which we use hemispherectomy palliatively, like we may have children who we know have a contralateral migrational abnormality, but their epilepsy is severe and almost entirely unilateral. That would be an example of a case in which we might still entertain the hemispherectomy, even though we know that there's some contralateral hemispheric pathology that's not ictally active. And we're doing that really to preserve developmental velocity and to improve quality of life or improve the ability of the parents to care for the child. And those are really selective cases, but palliative hemispherectomy is a thing and can be very, very helpful. And parents generally like having had it done. Hemispherectomy has undergone a lot of variation over the years, ranging from the pure anatomic hemispherectomy, which is on the left-hand side, which really is not done routinely anymore. There might be one or two centers in the country that are still doing it. Last I had heard, CHOP still does the anatomic hemispherectomy. The vast majority of centers will do a functional hemispherectomy, which is essentially key disconnections of all the commissural pathways, isolating the hemisphere so that the seizures can't spread to the good hemisphere. We at Children's do essentially a peri-insular functional hemispherotomy. Olivier Delaland, who is a retired pediatric epilepsy surgeon, a French epilepsy surgeon, was the first to describe the vertical parasagittal, which you see on the right-hand side. And that's still done today. Some centers that are promoting the endoscopic hemispherotomy, like Sandy Lamb at Northwestern, she does a variation of the vertical parasagittal hemispherotomy, in which you basically do a parasagittal craniotomy. And you're still doing a functional hemispherectomy, but instead of coming from the side, periopercular, you're coming from the top, through usually the middle frontal gyrus, all the way down through the insula into the temporal lobes. It's a very long reach. The variations of hemispherectomy, I think, all have in common that they are highly effective for the right patient. Anatomic hemispherectomy had by far and away the highest seizure control rates, but it came at a cost. The rates of hydrocephalus were nearly certain. And there's an entity called superficial hemosiderosis, which is essentially almost like chronic subdural hematomas that erode the good hemisphere. So a lot of those kids have become encephalopathic as they became older. So many centers have turned away from the anatomic hemispherectomy as the surgical therapy of choice. Hemidecortication was described in some Canadian and East Coast centers. It's exactly what it sounds like. But because you can't physically hemidecorticate the entire hemisphere, and it's quite bloody to do so, it's not something that was ever really adopted in the mainstream. And we covered the functional hemispherectomy that we do here. Pivoting towards palliative surgical approaches, palisotomy. Palisotomy, I think, is the mainstay palliative therapy aside from VNS for drop attacks, for atonic seizures, or for primary generalized seizures with rapid secondary generalization. We use it potentially the most frequently in kids with Lennox-Gastaut, but there are some other kids who might benefit from calisotomy. We try to screen these kids for having neurological and intellectual function that will allow them to recover from such a big operation. But I think the game changer is, for a long time, even here, in the last few years, we were still doing it open, interhemispheric transcallosal approach, trying to get as much of the corpus callosum as we could. Usually that resulted in an 80 to 90% callosal disconnection. A lot of that really depends on, I think, the topography or geography of the corpus callosum and how accessible, in particular, the splenium is. because that reach backwards towards the splenium can be very difficult and can be very long. And if the splenium dips down low behind behind the vein, it can be hard to reach that using the anterior approach. But the game changer really has been laser ablation. And what I'm showing you here is essentially an example of a schematic of how you could do it with a laser. And a lot of times now, we've done a couple, we're using 4 lasers, one anteriorly straight down into the rostrum, one posterior straight down into the splenium, and 2 cross lasers like this for genuine body. And what that's allowing us to do is, it's allowing us to do a complete disconnection in one shot, even though I think there's a lot of debate to be had as to whether we should be doing complete disconnections in one shot, and it's minimally invasive. So you don't really avoid the morbidity of the callosotomy, like the acute disconnection syndrome, but you avoid the surgical morbidity, everything from the incision to the potential for pseudomeningocele CSF leak or shunting. What's interesting is that we're actually right now, there's a large epilepsy surgery consortium that's putting together some data looking at multiple centers in callosotomy, and it looks like laser takes longer in the operating room. And for those of you who've done one, you can see why. You have to place 4 probes, you got to move them to MRI, you got to sequentially ablate each of the probes. It just takes a long time. So it's longer than the open surgery. And interestingly, the hospital stay is very similar to an open callosotomy because they get disconnected and they still require rehab. But there's a much lower blood loss and almost zero surgical morbidity that's associated with laser ablation, which are the benefits. Callosotomy is very effective for drops. Up to 70% will experience improvement in their drops, with 50% being completely seizure-free, which is slightly better than vagal nerve stimulation when you compare them head-to-head. It's not really effective for the complex partial seizures, the multifocals. That's probably about 20 to 30% seizure-free. And we've all seen what acute disconnection looks like. It's mutism, sometimes hemiparesis or apraxia, urinary incontinence. Sometimes kids don't want to eat or they forget how to swallow, and that can take time in rehab to recover. The rehab stay can be anywhere from 2 to 6 weeks, depending on how affected they are at baseline and how affected they are by their disconnection. Some of the disconnection probably is attributable to frontal lobe retraction during the open surgery, but even when you do it with a laser without frontal lobe retraction, you still get a lot of these things. Neuromodulation is the second, besides stereo EEG, is the second, I think, most transformative thing that's occurred in pediatric epilepsy surgery in the last 5 to 10 years. VNS is the one that we're all incredibly familiar with, but it's DBS and RNS that are really on the horizon. There are a couple of non-invasive techniques I wasn't going to really talk too much about. Trigeminal nerve stimulation is exactly that. It's stickers that are placed in the trigeminal nerve. It's being done right now in a research capacity. It's being used in both epilepsy and depression. It's showing some promising results. It's something patients can do at home. Some people are playing with transcutaneous vagal nerve stimulation. There's, I think, a European company that's come out with a transcutaneous vagal nerve stimulator. Unclear where that's headed or when that might show up in US markets, but it's out there and it's being tested. Repetitive transcranial magnetic stimulation, which we just started a program here at Children's, has a role in both the treatment of psychiatric disease, potentially the treatment of epilepsy, and we're using it now for pre-surgical mapping, particularly for language and motor, and it's really, really helpful. It's an augmentation of functional MRI. But it's really VNS, DBS, and RNS that are the kind of hot things right now. We all know VNS. VNS is the best studied in children as far as neuromodulation strategies are concerned. Essentially, there's a 50% reduction in 50% of children. If you look at the original pivotal trials, it's about a 42% median reduction in 18 months. Most studies have been observational, non-randomized open label studies. We think that targeting children when they're younger probably has the most benefit. Again, it's this whole idea of preventing developmental decline, restoring developmental velocity. But, we tell parents all the time it's not curative. less than 5% are seizure-free. DBS has been best studied in adults. Dr. Coe and Dr. Grannon are absolute experts in deep brain stimulation for movement disorder and are now rapidly becoming experts in deep brain stimulation for epilepsy. The Santee trial, which is now over a decade old, looked at the results of anterior nucleus stimulation in medically intractable epilepsy, likely of limbic origin, and it works probably as well as vagal nerve stimulation. One of the questions, there are a couple questions that are outstanding in children. One is, where's the best target? And we've implanted about 6 or 7 kids with Lennox-Gastaut in the central median thalamus based on a lot of literature that's been around for over a decade, and it seems to work. It seems to work pretty well. These are kids that have failed all surgical therapy, have had a vagal nerve stimulator with moderate improvement, and it appears that in the majority of them, central median thalamus deep brain stimulation provides additional seizure reduction. We've seen a huge range. It's probably going to be approximately a 50% additional seizure reduction on top of VNS. We have one child who's nearly seizure-free. We have some where the results have been equivocal, and then we have some that's sitting at sort of 25 to 75% seizure reduction range. Responsive neurostimulation, right now, the only responsive neurostimulator goes by trade name Neuropace, but there are a couple others that are out there in the works right now in preclinical evaluation, is an implanted device in the skull that is essentially a closed loop system. It allows for 2 electrodes, either subdural strips or depth electrodes. It allows for 4-channel simultaneous recording, and it reads continuous electrocorticography. Patients upload their data to the cloud. Neurologists are able to evaluate it and change stimulation parameters. RNS, when it was originally studied in the FDA pivotal trials, was really focused on neocortical localizable epilepsy. So it's going to be patients who, for instance, were, bitemporal, in which they wouldn't get resected. Instead, they would get depth electrodes in the bilateral hippocampi. Or if they were neocortical plus mesial temporal, they would get, a strip on the neocortical surface and the depth in the hippocampus. And what they found is that there was an approximate 60% reduction in seizures over time with RNS. Sometimes that got much, much better in time. What we're looking at in children is, again, adapting that same technique we just described in deep brain stimulation. We're looking at thalamic nerve stimulation. And there's a lot of exciting data that's come out over the last decade, particularly looking at central median, anterior nucleus, and pulvinar nucleus electrocorticography with multifocal epilepsies. And it appears that between 500 milliseconds and 4 seconds after ictal onset on the surface, you can reliably see electrocorticographic signature of the seizure in those thalamic nuclei. And the thought is that you can apply deep brain stimulation or responsive nerve stimulation principles to those thalamic nuclei and abort the seizure. And again, preliminary data does suggest that this works. And so we've implanted now several children with either pulvinar anterior nucleus or central median thalamus responsive nerve stimulation, and we're seeing the seizures in the thalamus, and we're able to responsively nerve stimulate them, and we are achieving seizure reduction. There's still a lot of work that needs to be done in this field, but this is really exciting for kids that were not surgical candidates before. If you had LGS and multifocal epilepsy, your surgical therapy ended at VNS. That was it. Maybe you get a callosotomy if you had drop predominant epilepsy, but if you didn't, VNS was the extent of surgical therapy offered. Now we're offering them neuromodulation with DBS and RNS. And I think time will tell what the efficacy of this is, what the long-term sustainability of these effects are, and whether or not it improves neurodevelopmental outcomes, which is, I think, a key question. This is just a graph more or less comparing the different neurostimulation techniques. Like I mentioned, DBS and RNS right now are only FDA labeled for above the age of 18, even though we're using them off-label in children. And we're seeing reduction in seizure frequency in these populations. And in the open label studies, particularly, we're seeing 50% reduction over 2 years out, or in RNS, over 2/3 reduction in their epilepsy at greater than 5 to 8 years out. what I want to draw your attention to in this table is go all the way down to the bottom, look at SUDEP risk. One of the arguments to be made for neuromodulation in kids who can't achieve cure is mitigation of SUDEP risk, and it does achieve that. VNS, DBS, RNS all achieve mitigation of SUDEP risk over time. And that's a primary driver for risk-benefit decision-making for epilepsy surgery in these children. So we think a lot about SUDEP risk when we're talking to families about the calculus for whether or not to intervene, even if we don't think we can achieve cure. What we really want to understand is that last row in the table is neuropsychological effects. We want to know if there's neurodevelopmental benefit to these palliative therapies. It seems like there is. The one question remains with anterior nucleus thalamus DDS is, are there neurocognitive side effects, particularly memory and depression, or things that have come up over time in the adult long-term studies? It is unclear what that is in children. But I will say in children, more often than not, we are targeting central median and not anterior nucleus thalamus. I think neuromodulation is an incredibly exciting area for innovation all over the board. Diagnosing and tracking epilepsy as an outpatient, bringing the EMU to the patient's home, automating EEG, understanding signal detection of electrocorticography, both invasive and non-invasively, improving our detection of lesions through structural and functional imaging, understanding brain mapping and connectivity, functionally improving our surgical tools, next generation ablative resective technology. We can go into that. And then, of course, improving our neuromodulation techniques with multi-channel detection, stimulation, even as simple as we'd like more than 4 channels of the RNS, we'd like more than 2 leads. We'd like smaller devices so that we can implant it in younger children whose skulls have not fully grown yet. All these things are ripe areas for improvement. Overall, we seem to be doing pretty well. There's certainly room for improvement in outcome. Up to 80% of children can be seizure-free after surgery. Of course, it needs to be the right surgery for the right child under the right circumstances. We think temporal lobe resections do the best. We know that if you have great seizure control in the first 6 months after epilepsy surgery, you're highly likely going to have an excellent long-term seizure-free outcome. And in those kids, up to half can be taken off 8 anti-seizure medicines completely. We know that if your pathology is more widespread, you have lower seizure remission rates. Even if you have bilateral interictal epilepsiform discharges, you could still be cured with epilepsy surgery, depending on what other findings we have on your phase 1 pre-surgical evaluation. We know that if you are MRI negative, if you have developmental associated disease, widespread disease on your postoperative EEG, or your resection is limited due to the presence of eloquent regions of cortex, you're probably not going to be seizure-free, compared to the other cohort. Morbidity and mortality for surgical epilepsy is incredibly low. And in general, the risks of surgery are less than the risks associated with the natural history of the epilepsy itself. After surgery, developmental quotients can improve, and that's key. Restoring developmental velocity, reducing developmental decline, improving caregiver ability. As parents get older, taking care of debilitated children can be hard. We all know that as we get older, how do we make it easier on the parents? Epilepsy surgery helps. IQ scores, behavior, attention indices, executive functions can be maintained or even improve. Kids do better in school. They have better social adaptation, but maybe even more important than all that is improvements in quality of life. After 3 years, quality of life indices actually normalize in temporal lobe epilepsy post-op patients compared to healthy controls. That means they're doing as well as their non-epileptic, non-surgical cohort after 3 years. That's pretty cool. That's very well studied and I think very compelling for epilepsy surgery. We know that kids, if they're not seizing, they have greater feelings of self-worth, social competence, are more likely to go to school, or more likely to have their families go to work, or more likely to have a job, hold a job, be more socioeconomically productive. I'm going to leave you with this last food for thought. In future state, a lot of groundwork has been done by terrific colleagues here, starting with Dr. Ojanen, Dr. Rada Mirza, Bill Dobbins, some of our genetics colleagues. We're looking a lot at molecular pathways disrupted in intractable epilepsy. mTOR is one that's an obsession of ours. It's a ubiquitous enzyme that's likely going to be disrupted in up to 50% of kids who have medically intractable epilepsy. This has led to some early phase clinical trials that we've done here at Seattle Children's Hospital using mTOR inhibitors like nabrapamycin in children who have failed epilepsy surgery. So these are children who've had a hemisterectomy, are known to have a disruption in the mTOR pathway, are still seizing, and it seems to be working in a lot of these kids. For instance, what you're seeing here is results of a phase 1 trial using nabrapamycin in a subset of children who failed epilepsy surgery. In some of these kids, they were having 100 seizures a week prior to starting drug. They failed hemisterectomy, failed multilobar resection, and they're seizure-free on drug. And that's led to an open label extension. We have some kids now who've been on drug for over 3 years. If you look, for instance, at P06, this is a child who had a hemisterectomy with a known AKT3 mutation, was having 100 seizures a week, completely developmentally disabled, has been seizure-free on mTOR inhibitor for over 3 years, which is super compelling. And I think this is just the beginning. As we start to identify more of these molecular disruptions, we can repurpose chemotherapeutics that are already out there looking at these pathways for oncologic reasons, and we could potentially restore function, reduce epilepsy in these kids. And I will end there. Thank you so much. I hope that people found that entertaining and helpful.
Yeah, great talk. Thank you so much. I know there are going to be some questions for the audience. I'll get the ball rolling here. What's the $64,000 question? I think is, the procedure that many people with temporal lobe epilepsy want isn't necessarily the one with the most efficacy, and so the experts, you and others, would not necessarily advocate for it as the number one choice for the best outcome. Yet
Louis, I think you froze. Anybody else, is it frozen?
Yeah, we're here, Jay.
Oh, okay. I'd love to hear Dr. Coachman and Grannon weigh in. I would just say you're right that people come, looking for the less invasive option. And to be honest, it's not unreasonable as a first step. The one nice thing about laser ablation is that it doesn't take ATL off the table. And sometimes the first attempt, the first surgical approach is what gives patients encouragement that they could be seizure-free after an epilepsy operation and brings them in, for the second operation, for the anterior temporal lobectomy. Up to 50% of patients can be seizure-free if appropriately selected with laser ablation. But to me, you don't lose anything. You may lose some time, but very unlikely you're going to lose much more than time. And it helps them in their surgical decision-making. Andrew, Ben, Jeff, Hannah, do you guys agree with that?
I'll jump in, Jay. I think that's right on, but there's also a group that they try, it fails, and they don't come back. So I really don't know the answer.
I think what's interesting, Jeff, too, is that some of these patients, it fails, and when they come back, they're happy with it. They're happy they did it. They're happy with the outcome, which is really fascinating. That's something we see a lot in the Harborview clinic. Ben, has that been your experience too?
Well, I haven't, probably been in practice long enough to see a lot of those scenarios play out, but I do think, based upon your earlier slide showing, that the time it takes to get to the surgical starting point is so long for some patients that there should be an awareness of, is the stepwise approach the right thing for an individual patient or not? So it's not right for everyone. And then the other factor here, I think, is the limits on the ability to prognosticate cognitively on how an ATL versus a laser would play for an individual, which is still, we have some predictions, but on a per individual, still pretty low predictive ability. So I think that's the major reason to consider that against the decrease in efficacy.
I agree. I think there's a lot of hand waving when it goes, particularly for dominant mesotemporal lobe ablation. I think for non-dominant, most of us feel compelled to offer ATL over laser because of the likely lack of neurocognitive morbidity. But I think, yeah, it's a real hot topic in dominant mesotemporal lobe surgery.
And I think to be provocative, I would also raise the issue of, at what point are epilepsy neurosurgeons going to cut the middleman out of the treatment algorithm process? And just like stroke care, we don't put every single stroke through a neurologist before we take care of it. We sometimes have neurosurgical stroke and we just take it over from the very beginning. We have our own referring groups that refer to us for elective care for prevention of stroke. When is epilepsy neurosurgery going to follow suit? Again, being provocative here, but I think it would be interesting discussion.
I think it already does happen to an extent, in lesional epilepsies, in which there's an MRI positive lesion, particularly in low-grade glial neoplasms. Those kids generally will go to the neurosurgeon first. However, it's really the localization of the epilepsy that we really count on our neurology colleagues in helping us with. And then no matter what, we really need their partnership in managing these patients pre and post-operatively medically, and managing expectations and some of the other comorbidities that go along with intractable epilepsy. At least that's my take. And I think even as we get better at automating localization, we're still going to need that partnership to holistically take care of the epilepsy patient. A lot of them have a lot of comorbidity, particularly in kids. They have neurocognitive comorbidities, they have psychiatric comorbidities, and as neurosurgeons, we generally are not probably the best equipped to tackle that.
I do think it's interesting that a lot of patients now are candidates to at least talk with a surgeon with neuromodulation on the menu, so to speak. Even if you shouldn't unilaterally be making the decision, it probably makes it reasonable for neurosurgeons to meet patients early on in the process, compared to kind of meeting right before the OR in some sense. It's not really cutting out the middleman completely, but being more involved from the outset to develop those relationships.
Any other questions for Dr. Hauptman?
I think Dr. Oseman had his hand raised.
No, I think you addressed it. Thanks.
Hi, Jay. This is Frank. Thank you for this great talk and very interesting even from the research perspective. And as you may know, I'm interested in mitochondrial disease-related epilepsy, and they present with lesions and refractory seizures. And I'm wondering, are they seen at any time, or is there any of those candidates for surgery, or even just neuromodulation?
Thanks, Frank. So we do see the mitochondrial kids for VNS. I think it's a question of whether or not they could benefit from DBS RNS. That's an outstanding question. Also, our mito kids are medically complex, and the way that they metabolize the anesthetic in particular is a little bit different than other kids and can provide some complexity for our anesthesia colleagues. However, that said, they are absolutely surgical candidates. I would argue that every single child with medically intractable epilepsy has a surgical option, and that neuromodulation in particular is an option for everyone. There are almost no exclusionary criteria for VNS. I mean, you kind of want to be cautious in kids who have central sleep apnea, for instance, but you can still do it in them. There's just a warning that comes along with it, maybe the need for a pulmonologist or even CPAP at night. But VNS is a non-brain surgery that's available to everybody. And I think we're going to see DBS and RNS, particularly as we understand the role of the thalamus in propagation and resolution of generalized multifocal epilepsy. It's going to end up being an option for everyone too. And we're working our way towards that, I think.
Yeah, that's very interesting, because it sounds like to me I have the opportunity to test VNS and other neuromodulation in in the research setting and preclinical and see the outcome, especially for a model where we have a ton of SUDEP, and see whether we can attenuate that rate.
I would argue, Frank, that the attenuation of SUDEP risk is by far and away the most critical and most concrete objective of epilepsy surgery. No different than when Dr. Kim is attenuating the risk of morbidity and mortality from a potentially an unruptured aneurysm. I mean, intractable epilepsy is the unruptured aneurysm. And so to me, they are almost identical in the thought process, in the way that we should be approaching it. Is attenuating risk of morbidity and mortality, which are concrete, well-defined risks. And the risk of any surgical intervention that Dr. Ogeman, Dr. Goldstein, Dr. Gran, and Dr. Ko can offer is much lower than the natural history risk of morbidity and mortality from the epilepsy itself. Not to mention the sort of hand-waving neurological developmental decline that we don't even put a number on, but we know it exists.
Yeah, very interesting. Thank you.
Well, I think we're a little over time, so we better conclude there. But thank you so much, Jay, for jumping in last minute and filling in for us and giving us a great overview that even non-experts like me could benefit from. So I appreciate it so much, and everyone have a great day. Thank you, Jay.
Thanks, everybody.
Thanks, Jay.
Thanks. And again, I just want to thank Jeff, Ben, Hannah, Andrew, great partners. Thank you, Louis. Take care.